So kind of like Dr. Ginsberg, I have the pleasure of working at a really special place, and it's not just the University of Minnesota. A couple of days a month, I go do a clinic at this pediatric hospital called Gillette Children's Hospital, and Gillette is it's this magical place, kind of like Rancho Los Amigos, where you wouldn't go to Gillette if you had a Wilms tumor. Gillette is a children's hospital that really specializes in neuromuscular conditions. So they have a huge population of kids with Duchenne's muscular dystrophy, myelomeningocele, cerebral palsy, and then they were really one of the first in the country to set up a brick and mortar adult longitudinal follow-up clinic. So we have this clinic called Gillette Lifetime that's about a mile away from the Peds Hospital, and it's a brick and mortar building, and we have clinic there 5 days a week, every week of the month. And there's med peds people there, there's wheelchair fitting people there, there's neurosurgery and urology, and of course those of us specialists only come a couple of days a month. But Jenna Kotorski, who's in the audience today, is a nurse practitioner that works with me there, and she really runs the clinic most of the month, and then I just come in a couple of days a month to scoop up some surgical cases from clinic. But she's really fantastic, and together we've learned a lot about neurogenic bladder in adults with cerebral palsy because we get this really unique concentrated experience where I think a lot of people will get a concentrated experience with spina bifida because they'll have an adult spina bifida clinic. But most people, I think, encounter cerebral palsy patients here and there in the midst of their other clinic. And we actually have a day devoted just to cerebral palsy and a day devoted just to spina bifida. So at Gillette Lifetime, we have about 300 adults with cerebral palsy, and we see about 200 of them in the urology clinic. So that's given us a really concentrated experience. So I'm going to spend a few minutes talking about what is cerebral palsy, because I didn't know much about it 5 years ago. And then I'm going to talk about a few papers we've put together using our experience at Gillette. So CP is a non-progressive, but often changing motor impairment syndrome secondary to lesions of the brain arising early in development, or what you'll sometimes hear as CP is a static injury in the neonatal period that leads to that leads to a disorder mostly manifest by motor impairment. So it's a heterogeneous disease because it's got heterogeneous etiologies, right? It's not defined by a chromosomal defect or something like that. It's defined by motor spasticity secondary to some kind of a neonatal brain injury. And that neonatal brain injury might be anoxia, it might be head trauma, a variety of different things. And so because of that, the phenotype is quite variable as well. You'll hear people talk about diplegia, hemiplegia, tetraplegia. So these are different ways to describe people with CP because they may have bilateral lower extremity spasticity and essentially like a paralysis of those legs because they're so spastic that they can't use them. The hemiplegia would be an arm and a leg on one side, and then we have a lot of people we see in clinic with tetraplegia. So again, it's almost like they have quadriplegia spinal cord injury because the arms and legs are so spastic and they can create very little voluntary movement in them. The incidence of CP is about 2 in 1,000 live births. The incidence goes way up in very low birth weight infants and in premature infants, but still more than half of the cases are occurring in normal birth weight, normal term infants. And when you look at adults with CP, the prevalence in the US is about 500,000. So these are 500,000 living now with cerebral palsy adults. The higher prevalence is mostly due to improved survival in CP And most of that improved survival is in the worst cases. Most people born with CP today will live into adulthood, and that wasn't always the case. So we've done a much better job of keeping the severe cases alive in the neonatal period, and then they make it to adulthood. It used to be that the death rate by 10 years, as you can see in this graph, was about 30% for all comers with CP. And that was in the 1970s. And if you follow these birth cohorts out by decade, you see the improving survival with each decade for people born with CP. So now about 95% live to 10 years. And as I said, the people who are doing better than they used to are those with the most severe CP. And of course, those will be the ones that are most likely to need our help when they get to adulthood. So I think it's important that adult urologists really start to understand the care of advanced cerebral palsy. So again, what is CP? A little deeper dive now. So it's a heterogeneous disorder, but universally characterized by a neonatal brain injury, non-progressive, and either neuromuscular spasticity or ataxia, plus or minus a cognitive delay. Do not think that all these patients have cognitive delay or intellectual disabilities. They don't. They can have an expressive aphasia or dysphagia, and this expressive aphasia can make it so that you interpret that there's not much going on the inside, but actually they're really bright, intelligent on the inside. They just can't express that to you. They can't answer your questions well, but with the right kind of adaptive technology, such as these keyboards with pictures on them that then speak words for you, you can tap into just how bright they are. It's well described that a lot of these people have an anxiety disorder, a seizure disorder. Some of them get labeled as having a behavior disorder, some kind of acting out, probably because it's hard for them to express what they're thinking on the inside. There's a classification system used in kids, and we use it loosely in adults as well, where you classify people with CP into different levels of severity. Of course, you can classify them based on diplegia or tetraplegia, but you can also classify them based on what motor tasks they can perform. And we call that the Global Motor Function Classification System, or GMFCS. And this goes from 1 through 5. So in level 1, they're basically walking without any assist. Level 2, they use some assist, like maybe a cane or a walker. Level 3, they're using a walker almost all the time, or they might be in a wheelchair some of the time. Level 4, they're in a wheelchair, but it's a self-propelled wheelchair, or they're driving a joystick. And level 5, someone else is pushing their wheelchair because they pretty much have no motor control on their own. So CP is associated with a varying penetrance of many associated conditions, and many of these conditions, but not all of them, do correlate with the degree of physical impairment. And as I said earlier, the most sensitive of these is probably the intellectual disability. So the definition of intellectual disability is an IQ less than 70, and 31 to 65% of people with CP will have an intellectual disability, but that means that about half of them don't. And so you definitely want to give them a chance to communicate to you what their level of intellectual function is. I make it a point when I go in and talk to them in the clinic that I talk to the patient first, and if over the first minute or so the caregiver redirects the questions towards them and the patient proves to be non-responsive, then I start talking to the caregiver. But you can only imagine how offensive it would be to them if you go in and just ignore them and first start talking to the caregiver. The intellectual disability actually does correlate with the severity of spasticity, but that's just a correlation. That's not 100% of the time. So you can't just assume that they have intellectual disability. Additionally, these IQ tests don't really account for some of the motor impairments and other expressive aphasia problems they have that kind of trap in their intellect. So they might perform poorly on an IQ test, but still be really bright. So Jim Grimm here, who wrote this book, he's the one in the wheelchair. He passed away a little while ago, but he was a patient of ours at Gillette. He wrote this book. I mean, you would look at him with his spastic tetraplegia, expressive aphasia, difficulty controlling his secretions, drooling, and you would just make some assumptions about his IQ, but he actually was able to dictate this entire autobiographical book about his life. So it's a great read if you ever get to it. 24 or 40% of them will also have epilepsy. Many of them will have visual deficits or hearing abnormalities. So how does CP affect the bladder? So CP, by definition, is a brain injury. It's a suprapontine brain injury. And because it's above the pons micturition center, by definition, CP affects the bladder as an upper motor neuron bladder. So what you would expect is urinary urgency, urgent continence, detrusor overactivity, maybe some reduced bladder compliance, maybe some reduced bladder volume. A unique thing we see that I'll show you a little bit later is because of the severe muscle spasticity that they have in their limbs, they'll actually also get a muscle spasticity of the pelvic floor. So their constipation, their fecal constipation they have, it's for a totally different reason than the people with spina bifida, right? So the spina bifida people might have a weak sphincter, but the CP patients tend to have a really tight pelvic floor. They get constipation because they have outlet obstruction of their rectum. And it's the same with the bladder. They'll have such severe pelvic floor spasticity that they have something that looks like DESD that Dr. Ginsburg showed you earlier, but it's actually pseudodysynergia. And try to spell that. I think I spelled it 5 different ways in this presentation. See if you can find all of them. So they'll have pseudodysynergia so that when they're voiding, their pelvic floor contracts. And what that means is that over time they develop more and more and more retention. And so they can look to you like they have a big flaccid bladder. And I'll show you that more later. 50% of them overall are affected by LUTs. The bladder, we've found, can actually be a progressive problem, even though CP is a non-progressive condition. And these urinary symptoms often get ignored. So are there ways that you can predict who's going to have a urinary dysfunction? So there was a cross-sectional comparison of kids with CP, and these are some of the things that had a higher odds ratio in those people with urinary incontinence. So they were more likely to have a lower IQ, they were more likely to have difficulty controlling their secretions, they were more likely to be on laxatives, have spasticity, and have a high GMFCS score. Our patients that we see at Gillette, they almost have all of these. We're seeing some pretty severe cases. So let's talk about one project we did, which was on urodynamics. We wanted to characterize what the patients with CP look like on urodynamics. But urodynamics is really challenging to perform in these people. A lot of them can't communicate, all those things like first sensation, first urgency, maximum capacity. They can't tell you those things. Additionally, you go to put a catheter in them and it hits the spastic pelvic floor and the catheter just coils up in the bulbar urethra. So it can be really, really tough to perform urodynamics on them. So we don't perform intake urodynamics on every patient with CP because it can be pretty traumatic for them. So we only perform it on select people. And as you can see at the bottom of the left panel, we'll perform it for people in retention, people with some irritate avoiding symptoms or UTI, hydronephrosis. Of all the 300 people at Gillette with CP, we see about 211 in our clinic, and we did urodynamics on 49 of them. The mean age of the people we did urodynamics on was 31, and 55% were male. You can see that their GMFCS scores were actually on the lower end for our clinic because, again, the people with severe GMFCS scores, doing urodynamics in them is more difficult. Most of them were living with their parents. So this is a log compliance on the Y scale versus maximum systometric capacity on the x-axis, where we're plotting out. Here you can see that as their maximum systometric capacity goes up, their compliance also tends to be better. So that you could kind of draw a line going like this. But this is a compliance ratio of 20. So you can see that about half of the patients fall below a compliance of 20, meaning they've got a pretty poorly compliant bladder. Indeed, when you look at specific findings, about 30% of them have detrusor overactivity. 39-40% have a DLPP over 40, so that's pretty bad. But again, we're only performing urodynamics on some of our ones who have like hydronephrosis and other significant problems. 12% had pseudodysynergia, and the maximum systometric capacity was all over the place. I like to think of which patients have what I'd call a hostile bladder, meaning they have a small systometric capacity and they have a poor compliance. Because if someone has let's say a DLPP of 40 at a volume of 500, that might not be such a bad thing to have, right? You can just tell them, cath before you get to a volume of 400, you'll probably be okay. But if you have a DLPP of 40 at a volume of 200, you're going to get in trouble. So about 16% of them had a small systometric capacity and bad compliance. So do all patients with CP need CIC and anticholinergics? Because a lot of them are having pretty bad urodynamics. Or can you just observe them? This is now looking at all the patients, again, the 211 that we see in our urology clinic. Of those, we chose to put about 121 of them on what I would call a observational or non-intervention pathway. So these are people coming to our clinic with urinary symptoms, meaning that maybe the caregiver is saying this patient voids into a diaper all day, and then you do an ultrasound and their bladder has like 900 cc's in it, but there's no hydronephrosis, and they've never had a UTI in their life, and they have no bed sores, and they're not complaining about the incontinence, the patient is not, and they're in a good group home where they change their diapers pretty frequently. I have a hard time telling them they need to go on CIC, especially because they've got pseudodysynergia probably, and cathing through that spastic pelvic floor is going to be painful, and you're probably going to start causing UTIs. So a few years ago, we started kind of standardizing this pathway where we would put people on this observation where if they didn't have an augment or they weren't already on CIC or indwelling catheter, we followed these people and did nothing, didn't put them on anticholinergics. I'm afraid if I put them on anticholinergics, then I'll have to start cathing them. So even though they have an upper motor neuron bladder, we're not starting anticholinergics. So of this population, they tended to be the GMFCS 4s and 5s, because the 2s and 3s are saying, Doc, I'm bothered by the incontinence. Put me on an anticholinergic, I want to start self-cathing. The 4s and 5s, they oftentimes aren't complaining, and intervention would be higher risk in them. These patients, about 40% of them are nonverbal. A lot of them are just voiding into a diaper. Some of them are volitionally voiding, meaning they get put on a toilet maybe twice a day, and they might be in retention the rest of the day. And so why would we do what I'd call non-medical management? Because history taking is challenging. The caregiver might tell you that the patient's in retention all day and then voids if you put him on a toilet once a day, or they might we change his diaper twice a day, sometimes it's wet, sometimes it's not. Like, I have a hard time figuring out what is really going on with that person's bladder. Are they in overflow? Are they having urgent incontinence? It's really hard to know. And as I said, urodynamics is challenging. I feel like I need urodynamics if I'm going to put them on anticholinergics and intermittent cathing. This is some of the challenges we face, but we put them on this protocol where we did conservative management, meaning we just observed them, we didn't cath them, we didn't give them anticholinergics. We did an annual renal bladder ultrasound and an annual creatinine, We did functioning toileting education, meaning trying to get the caregivers to put them on the toilet twice a day and trying to get the patient to understand that this was the time when they needed to pee. And changing the incontinence padding briefs frequently, and good perineal hygiene. And doing those things, maybe we can prevent the UTIs, the hydronephrosis, the bed sores, the bothersome incontinence. We initiated CIC or indwelling catheter or urodynamics if they had prolonged episodes of retention, like longer than 16 hours on multiple occasions, multiple trips to the ER for cathing, if they had more than 2 febrile UTIs in a year, if they had hydronephrosis that was new or worsening, if they complained of refractory lower urinary tract symptoms, or if they had bothersome incontinence like skin breakdown, or if they complained about the incontinence. These would be reasons for intervention. And this shows you the outcomes. So out of 121 people that we put on this observation regimen, the green box in the middle shows you that 23% of them failed and went on to some type of intermittent cathing, but 77% of them stayed on this observation regimen through a short follow-up of 18 months. The reasons that we took them off of the observation regimen were 9 patients hydronephrosis, 10 patients multiple bothersome episodes of retention, and 9 patients refractory lower urinary tract symptoms that were bothering them. And then when we put them on CIC, the outcomes of CIC then on the far panel were that 9 of them continued the CIC per urethra, 10 did not like CIC per urethra, and so we did a Mitrofanoff, and 9 of them ended up discontinuing the CIC and just going back to the observation or getting an indwelling catheter. So, surgery has significant risks in this fragile group, but as you can see, 77% of the time we're able to observe without CIC or surgery without sequelae. Of those that we have done surgery on, 10 catheterizable channels, 5 with an augment, and 1 intestinal leak, 1 small bowel obstruction. Just like the spina bifida population, stone surgeries in this group are very high risk. We only had 3 in this group, but 2 of them developed sepsis. I did the operation on one of them, and he actually died of TUR syndrome intraoperatively, and that was, very traumatic. And I stay away from the operation in this group. I think there's something unique about their having some baseline brain injury to begin with that makes them, in my N of 1, more fragile with the sphincterotomy. Botox has been without complications. So to wrap this up, I think 3 more slides. So when you do operate on these people with CP, when you do a urinary diversion, there's some special things you want to consider based on my experience operating on them. Intraoperatively, there are some positives. Compared to the spina bifida patients, these patients just tend to be thin. I can't explain the differences, but they tend to be thin, and that makes the operation a little easier. They also tend to have normal intra-abdominal anatomy. Spina bifida patients, sometimes I find their cecum underneath the liver. That's never true in CP patients. It's always fairly normal on the inside. Now they might have severe scoliosis. They might be kind of contracted in their torso, but overall their intestinal anatomy is normal. They'll have a weak abdominal wall, of course, and that leads to problems with hernia. A lot of them will have a baclofen pump. That doesn't really bother me if I'm doing a midline laparotomy, but it can get in the way of putting in a stoma because most of the times the baclofen pump, for whatever reason, goes on the right side. So that can get in the way of an ileal conduit. Or if you're doing robotic ports, you just have to go a little bit higher to avoid the baclofen pump. Post-op, watch out for aspirations because a lot of them have trouble controlling their secretions. Constipation, ileus. I can't overemphasize how important it is to have a caregiver in the bedroom with them to help you with communication because a lot of them you can't communicate well with them, but their caregivers can understand the verbal, their style of verbal communication. And of course, get them physical therapy, get them out of the bed. And then lastly is this issue of pseudodysynergia. So I've observed that some patients that we need to put on CIC, okay, because they're wet and they want to be dry. They want to go on CIC, and they want to do it through a Mitrofanoff because they refuse or can't tolerate CIC per urethra. So you're going to do a Mitrofanoff on them, so then you do urodynamics on them because you want to make sure you don't have to do an augment at the same time. But what I've observed is that in a lot of these patients, because they've never been on CIC before, they've kind of been in chronic retention and just overflow incontinence. You do the urodynamics and it looks like this. So this patient has an 850 cc capacity bladder. And then he has a terminal detrusor spasm at the end and has severe pseudodysynergia. And you look at this and you say, this person doesn't need an augment when I do his Mitrofanoff. But sure enough, 6 months later, I'm injecting Botox and I'm thinking maybe I should have done an augment. And so I think what's going on is that this bladder's been over-distended, and then you finally decompress it by putting them on CIC through the Mitrofanoff, and it just shrinks down to something much smaller. And so we saw that happen in 6 out of the 8 people that we did simply a Mitrofanoff on. And when I look back at the patients, all 6 of those had basically been in chronic retention beforehand. And so even though their urodynamics showed good capacity, they probably didn't really have good capacity. So we're working on investigating that further, and that should be a AUA abstract. But you should at least consider that these patients really do have an upper motor neuron bladder, and they can fake you out as having something that looks like a flaccid bladder. So in conclusion, remember they can have great intellectual capacity. Urodynamics in our hands has shown concerning findings in almost half the patients, but we've also been really selective on whom we do urodynamics in. Maybe we should be doing it more often, or maybe we're just really good at picking who's gonna have bad urodynamics. I don't know the answer to that. Observational management can be successful, but our follow-up so far is pretty short. And then surgical considerations, remember this thing about the pseudodysynergia and the chronic retention, and remember the post-op communication is really critical. So thank you.